So the floor for you. You are the moderator. You can start the session, please. Thank you very much.
I'm not really sure if all the participants are. Oh no, all the participants are here. Okay, so wishing
Yeah.
everybody a very good evening, and I think we can start our pediatric session. I would like to invite Dr. Hayat Khan, who is a pediatric ophthalmologist and
Can he
strabismologist.
is not here, Dr. Hayat, I think. Can we start by others because he is
Sure,
stuck in the
sure.
clinic? Yeah.
So I think we can go on to our second speaker, Dr. Simarajan Singh. I see him here.
Yes, he is there.
Yeah, so Dr. Simarajan, who is I would like to introduce him as the Assistant Professor, Vitreoretinal Surgery Department, Advanced Eye Center, PGI, Chandigarh. And he is going to be talking on the various gene therapy for inherited retinal diseases in children. Dr. Simarajan Singh, over to you.
Thank you so much, and thanks to Dr. Amri for this opportunity. So I'll be speaking on gene therapy and clinical clinchers in inherited retinal disease in children. So inherited retinal disease can present in various morphologies, and while we may be able to classify them morphologically into a few subgroups, they are genetically very diverse. If you look at them, they have a lot of overlap and literally more than hundreds of genes that are involved. But since we know that these are genetic disorders, so gene therapy is the kind of way to go for these disorders, and many advances have been made in gene therapy over the last decade or the 2 decades. So the various options that are available for gene therapy, what we have basically is that there is a protein that is not being formed that is required in the body due to a defect in the DNA. And the options that we have is either to replace the whole of the missing protein, or there is a protein that is fallacious and we need to decrease the quantity of that protein. So the options that are available to us for that currently are the gene specific options, which include gene augmentation, which is the most tried out option right now, and with the only approved gene therapy, that is the RP65 therapy, Vortigene Neparovat. The same therapy is used using gene augmentation, which replaces a missing part of the genome that is missing, and that produces the missing the protein that was not being formed earlier, leads to restoration of some function. They are usually delivered with the help of viral vectors. Gene editing is something that is coming in a big way, especially with the advent of the CRISPR gene editing modality, which helps in mainly the autosomal dominant variants, as well as genes that are very large and cannot be packed into the viral vectors to delivery into the target cell. And then, of course, we have RNA transcript editing, which helps in decreasing the bad proteins, which may not be necessary. So these were gene specific modalities that are available. There are some gene non-specific where we don't use the genetics, but we do some downstream regulation of the functions of the protein and help in sustaining some of the function in these cases, which can help like neuroprotection. So there is a rod-derived cone viability factor, which helps in sustaining the cones even when the rods are getting lost in a rod cone dystrophy. So if we can supplement that, we may be able to prolong the life of the cones further. And even in the last stage now, optogenetics is kind of being tried. That is when the entire rods and the cones are lost, but we still have the rest of the pathway intact. So the optogenetics kind of helps in stimulating that pathway with the opsin function to light, and so that some vision can be restored in those cases. So these are various options that are available, and the path to gene therapy has been very long and it's still going on. But in 2017, we have the first FDA approved gene therapy for RP65 Leber's congenital amaurosis, and there are many more that are in the pipeline, and these are various clinical trials that are ongoing for multiple disorders, trying out various modalities that I just shared. But what is needed for this is accurate diagnosis of the disease, and that is the most important thing, and an early diagnosis of the disease, because the more rods and cones we have left, the better it will be for the gene therapy to function. because if there are no rods and cones left, there may be no advantage of replacing the correct gene into the DNA. So an early diagnosis is desirable, and also it can help parents and families plan education and make more informed career choices. So it is important to recognize some of the clinical clinchers which can help in early diagnosis of these patients. And I'll just be sharing a few cases of various diseases that we see commonly, and also for which gene therapy is being developed currently, so that we can recognize those diseases. Coming on to the first one, that is achromatopsia. So this is an example of a case who presented to us very early, almost at when the child was 3 months of age, and the parents brought with the complaint that the child has nystagmus, wandering eye movements, but nothing could be diagnosed at that point of time. There were thoughts of CVI, there were refractive error was checked, prescription was given, but no diagnosis could be made. Again, 2 years of age, the child was again seen refractive error, nystagmus had decreased. 3 years of age, doing well with glasses, but then again, the problem of nystagmus was there. At 4 years, the child himself complained that that I am not able to open the eyes when I go outside, photophobia. So that was the first clue that we could be dealing with some kind of a dystrophy or a cone dystrophy, and we had a pediatric retina clinic referral for the same. So this is the fundus of the child. When you see it, it looks absolutely normal. Wide field fundus photograph. Even if you see a zoomed up image, it's hard to find out any abnormality in the fundus. So, but once you do an autofluorescence, you see this nice ring of hyperautofluorescence that is present at the posterior pole, just surrounding the fovea, which gives you a clue that yes, something is abnormal. And when you do an OCT, it's difficult to do it in these cases because they have very much wandering vision. But if you can catch this optically empty zone at the posterior pole, that signifies greatly towards a cone dystrophy or achromatopsia, and we could find a pathogenic mutation in this case in the CNGB3 gene. So an early age of onset, hemarlopia, nystagmus that has improved with age, a hypo-FAF with a ring of hyper-FAF at the fovea, very posterior, and a focal defect on OCT point towards achromatopsia. Coming on to Leber's congenital amaurosis. So this is something that is reverse of achromatopsia. Those children are sensitive to light, and they have light gazing. They would be gazing at your indirect ophthalmoscope or torch very much. And this behavior is important to recognize, where the oculodigital sign, the child tries to stimulate vision by pressing on the eyes. So these are indicators, and when you see the fundus, you have this hyperpigmented spots all around the fundus. And when you do a genetics, you get a pathogenic mutation in the LCA5 gene causing Leber's congenital amaurosis. So again, early age of onset, light gazing, wandering vision, oculodigital reflex of Leber and and normal looking to hypopigmented fundus are signs that indicate towards LCA. Coming on to CSNB, which can again be sometimes difficult to diagnose because the patient is not seeing anything and you are not seeing anything. This was a 7-year-old boy who presented with complaints of poor night vision, labeled unexplained visual loss repeatedly. The patient was 6/6 vision, but they had a very specific complaint that he can't see at night. This was the fundus. You can see this kind of shiny reflex are coming out of the fundus, a yellowish glow of the fundus, and the OCT and other findings were absolutely normal. But once you dark adapt this child for an extended period, you can see the difference in the color of the fundus that is coming up. This is the typical Muzio Nakamura phenomena, and you can see this difference once you flash the fundus again after dark adapting for a prolonged period. You can see the difference between the normal fundus color and the altered color produced from the flash. And we found a pathogenic mutation in the SAG gene, which signifies Oguchi's disease. Again, it is important to recognize these cases because here the prognosis is relatively good. The vision is going to be good and they are going to remain stable. So it is important to inform the patients of the same. Coming on to another important cause of night blindness, that is enhanced S-cone syndrome. Here, the typical findings are this mid-peripheral involvement of the fundus, which can be picked up very classically on autofluorescence, where the involvement is more around the arcades, not in the periphery, not in the center, but around the arcades. And of course, you sometimes get the sheetic spaces at the posterior pole as well. And the ERG is also pathognomic in these cases where you have a very similar rod and cone response present. So clinical clinchers can be night blindness, increased tapetal reflex in the mid-peripheral fundus, which is the location of the S cones, and sheaths at the posterior pole. Another important dystrophy that we commonly see in childhood is the X-linked retinoschisis. Sometimes they may be you may confuse this for a detachment, but once you look closely at the posterior pole and you see this spoke wheel pattern kind of at the posterior pole, that is very characteristic of juvenile X-linked retinoschisis. And of course, if you can do an OCT scan, you can find these sheetic cavities. Important to not to label them as macular edema. And you can see this split which is within the retina and not below the retina. And yes, you can find a pathogenic mutation in the RS1 gene that causes retinoschisis. Stargardt's disease is another common disease that we see in childhood, and they come with low vision. So it is important to recognize these whitish flecks that are present all around, which can be present very early, and you don't have that typical bronze beaten appearance at the posterior pole as yet. But if you can pick these up, these are very classical for Stargardt's disease. And the OCT now shows you atrophy here, but you don't have the classical bronze beaten appearance. So low vision in childhood, foveal hyperpigmentation, later a bronze beaten appearance, and presence of the hyperautofluorescent flecks, which indicate towards Stargardt's disease. Best dystrophy usually looks very classical, but like this case had just come with retinal detachment in the right eye post-trauma. Left eye, we just incidentally saw this. Patient did not have any complaints, was 6'9", but when you do an autofluorescence, you see this hyperautofluorescent deposits at the posterior pole, and these are the vitelliform-like deposits at the posterior pole with shaggy photoreceptors, and genetics showed a BEST1 mutation indicative of best disease. Coming on to the CRB1 associated rod cone dystrophy, amongst the rod cone dystrophies, which has some very characteristic findings. And if you look at that, it may look like a typical rod retinitis pigmentosa, but you see along the vessels, there is sparing of retina along the vessels. And this is something very classical of CRB1 associated rod cone dystrophy. And if you can see this perivenular sparing and sometimes presence of secondary VPTs and exudative RDs, they are indicative of CRB1. Syndromic rod cone dystrophies, you need to look at the patient as a whole. This fundus may look like a typical retinitis pigmentosa, but when you look at these two children, you can see the kind of truncal obesity that is present and the presence of polydactyly. And sometimes the parents may have gotten these extra fingers removed, so you need to ask that history particularly. So this is typical of syndromic rod cone dystrophy, Bardet-Biedl syndrome. Also asked about hearing loss that may indicate towards Usher syndrome. And something that we very commonly miss, FEVR, is another retinal dystrophy which may not be treated with gene therapy, but is otherwise easily treatable if you pick it up. So this was a 12-year-old girl who presented with this kind of, she came with complaints in the left eye, low vision, but when you see the right eye vision was normal, but you can see this proliferation in the mid-peripheral retina, which is indicative of FEVR. And when you look at the parents, this is the fundus of the mother, the supranumerary vessels coming out of the optic disc and kind of ending just short of the ora serrata, which is indicative of stage 1 of FEVR. And in this, the genetics revealed a mutation in the NDP gene, which is known to cause FEVR. So to conclude, we now have the tools to reach a conclusive genetic diagnosis in most cases of inherited retinal disease, but we have to suspect something is wrong first to get to the point of genetics. Early diagnosis is even more vital now given the advent of gene therapy, and more treatment options are going to be available in the near future. Catching a few of these clinical clues can help in picking up these diseases at an early stage and helping our patients. Thank you so much.
Thank you, Dr. Simarajan. That was a very, very, very informative talk, and you had nicely depicted everything with pictures. I think we'll take all the questions towards the end of the session. I'd like to invite the second speaker, Dr. Hayat Khan, who would be talking on the management of Duane's retraction syndrome. Dr. Hayat Khan, over to you, please.
Hello.
So, hi, sir. Hi.
Hello.
Thank you.
Hi. Hello, everybody. So I'll just share my screen. Are you able to see my screen?
Yes, we are.
Hello.
Yes.
So hello, everybody, and thank you so much for the Asami Hospital meeting and Dr. Amri for giving us the opportunity to present. So without wasting any time, I will be taking up the topic of Duane's retraction syndrome management, no financial disclosures. So Duane's retraction syndrome, first of all, we need to know what is the hallmark of this disease. It's a cranial disinnervation syndrome, which is congenital and has a limitation of both sometimes adduction, sometimes adduction. There is narrowing of palpebral fissure with retraction of the globe on either adduction with sometimes upshoots or downshoots. So if you see, the combined mechanism is mechanical, innervational, neurological, and genetic. So in this busy slide, I would like to just go in and show you exactly what is, how Duane's 1, 2, 3 and the synergistic divergent types are. So first of all, if you see the first slide, that is the Duane's type 1, if you notice, are you able to see my slides?
Yes, yes, we are able to see your slide.
So the type 1, what happens is the sixth cranial nerve is not supplying the lateral rectus. Instead, the third nerve starts supplying the medial rectus as well as the lateral rectus. So what would be the end result? There will be an adduction. The eye will be moving in. In type 2, what happens? The lateral rectus has a good supply of the sixth cranial nerve, but what happens every time the third nerve gets activated, it starts supplying both. So what happens? That the patient still has an XT because there is a double supply here. The type 3, what happens is that the sixth nerve is not working and supplying the lateral rectus, while the medial rectus equally supplies both the lateral and the medial rectus. And what will happen to something when you are contracting both sides together? It will just have a retraction. So only retraction will happen. And lastly is the most unique type where sixth nerve is not working to supply the lateral rectus. But what happens that the third nerve, rather than supplying majority to the medial rectus, starts supplying the lateral rectus. And every time the person wants to do the adduction, instead of adduction, there is a opposite abduction movement. So these are the different ways in which you can easily understand how the eyes will be going. So 2 of them will have XT, one have the type 1 will have ET, and type 3 will have only retraction in most of the cases. So this is a type 1 esotropic Duane syndrome. So if the amount is very low and there is not much of an abnormal head position and stable, we don't want to do the surgery. So my talk would be more to do whether we need to do surgeries or not. This is interesting. Twins, if you notice them, the way they both are standing in my clinic, if you notice, they both have opposite abnormal head movement. If you notice, they both have Duane's retraction syndrome, what we call the mirror imaging. So there is a genetic incomplete penetrance with variable expressions of type 1, which is there. And you see, this is the first twin with a normal head position to the right, while the other one has to the left, which needed a surgery. Now, going further, sometimes the surgery is not needed only if there is very mild retraction. You don't want to, and the abduction is very limited. So we sometimes leave the patients and no need to do the surgery. While sometimes you'll see the condition is bilateral. This is a type 1 bilateral Duane syndrome. And these cases, definitely you would like to operate. So Let's go in. What are the indications of surgery? So a significant misalignment in the primary position and significant head position with poor cosmetic appearance. And of course, as you see, narrowing of the palpebral fissure due to retraction, which is more than 50% of the total amount, and sometimes significant upshoots. As you can see, these are upshoots and there is retraction. So definitely all of these will go a long way in making our decision to do the surgery. So we need to see the type of heterotropia in the primary position, the presence of compensatory head position, the severity of retraction, the presence of upshoots and downshoots, or the innervational and mechanical mechanisms, how they are, whether one or both of them are there, and whether it is a unilateral or bilateral. All of them put together will look at how we will manage our cases. Always remember, preoperatively, we need to have an adequate counseling of the patient, very essential that we need to give them realistic goals. What can we achieve? What will be what we can achieve and what we cannot achieve? And always try to avoid the resections because they may cause more retraction. So quickly, I'll go for a few cases. Case 1, 39-year-old female. If you see abnormal head position to the left turn, and when we went in and we did the surgery, if you see the preoperatively, if you notice here, the left esotropic Duane syndrome, we went for left medial rectus recession of 7 millimeter under GA, and this is the post-op result. So if you see that the abnormal head position went off, the retraction also improved. And if you notice, you look at the pre-op and the post-op, you see the amount of retraction has also improved. The eyes are looking almost equal, and abnormal head position has also improved. Second case, a young male who came with abnormal head position with the globe retraction and upshoots. So this guy, again, if you notice here, that he has had this problem, the left esotropic type 1 with severe retraction and upshoots. And what we did was, we went ahead with the surgery with the left medial rectus recession of 6 millimeter with Wright's modification of Hamel-Sheen's procedure of the left superior rectus under GA was done. And globe retraction was considerably reduced. If you notice here, this is how he is post-operatively, if you notice here. So this is how he was pre-operatively. So this is it. Now coming on to third case, a 6-year-old Yemeni girl, again, with a normal head position. We did bilateral medial rectus recession 7 millimeter with Wright modification of Hamel-Sheen superior rectus and inferior rectus under GA. And we found this patient post-operatively went very well. So there was an improvement in the abnormal head position, the retraction also improved, and this is it. So quickly going in, surgeries of Duane syndrome, if you notice esotropic type, we need to recess the ipsilateral medial rectus on the same side. But sometimes we need transposition of the vertical recti of the to the insertion of the lateral recti. And sometimes when there is more of retraction, then we can have an asymmetric recession of both medial and lateral rectus muscle. Now, in terms of transpositions, there can be different modifications like the Foster's modification, or we can Hamel-Sheen's procedures with Wright's modification, which is one of my favorites that I do. And of course, these cases do pretty well. Now, so for large angle esotropias, bilateral medial rectus recession is required. Sometimes posterior fixation suture to the normal medial rectus may also diminish the adduction. So this can be helpful, this modification. In exotropic, again, the same way, we recess the ipsilateral lateral recti muscle. And if there is globe retraction, or if there is, then we can unequally recess both the lateral and the medial rectus. In cases with upshoots and downshoots, a wide split of lateral rectus is very helpful. And of course, I have already told for large exotropias, you have to do both bilateral lateral recti recessions. And retraction, I have told you, asymmetric medial and rectal recessions where more of the lateral rectus recession is needed. In orthotropic type, again, a Y split of the lateral recti and ipsilateral recession of medial and lateral recti will be helpful. This is how we do the Y splitting and the recession of the lateral recti muscle. If you see in the lati, we have done this, and it works pretty well, especially in cases of upshoots and downshoots. Globe retraction, as we have already discussed, if it is isotropic type, more of medial rectus than the lateral rectus. If it is exotropic, then more of lateral rectus than the medial rectus. And if it is the type 3, then of course, equal amount of lateral and medial rectus recession will be helpful. Upshoots, I have already discussed, and downshoots, the Y-plasty helps with recessions. And I have very happy with the results. Sometimes, so I'm just putting it all together. The take-home message, doing retraction syndrome consists about almost 5% of all strabismus, and adequate counseling, especially what we can improve and what we cannot improve, is very important to inform the patients. And we need to inform that certain things will never be perfect. A proper diagnosis, evaluation, and a good surgical planning is needed for the best functional and cosmetic outcome, and every patient has to be individually prioritized. Every surgery has to be individualized. And of course, if there is amblyopia present, we need to attend to amblyopia before we go embark on surgery. Thank you so much. I think I finished in time.
Yes, of course you did. And it was a very, very, very informative talk and all covered up in very good time frame. Let's move on to our next speaker, who is Dr. Shweta Chaurasia, who is an associate professor in the Department of Pediatric Ophthalmology and Strabismus at PGI Chandigarh. And she's going to talk about an update on myopia control, something that Dr. Hayat spoke to us about yesterday as well. So over to you, Dr. Shweta.
Thank you. Thank you for the opportunity. Good afternoon, everyone. My talk will be on understanding the paradigms of progressive myopia and the science and strategies to control. So we know that the myopia has become a major health burden and has evolved as an epidemic. With the 28% of the population myopic, it has been affected by 2010, and it is estimated that 50% of the population will be myopic by 2050. If we talk about the epidemiology, the Western population has shown a prevalence of around 23 to 70%, whereas Asian children have shown a prevalence of 70 to 90%. India is coming quite fast here with the 7.5% prevalence in the school-based study, whereas in the urban population, it is 15%, whereas the population-based study in India has shown a prevalence as high as 30%. We know why we need to control, because myopia is one of the leading cause of blindness in the world, and we know what are the complications of myopia. We talked earlier about the retinal detachment. It has seen that if the refractive error is -1 to -3, the retinal detachment risk is 4 times, whereas it is 16 times if the number shoots more than -6. So there are 2 theories of progression. One is the accommodation lag theory, which says that when there is accommodation lag during near work, there is foveal hyperopic retinal blur, which induces an abnormal axial growth of the eye. Whereas another theory says that it's not the central retina, but it's the peripheral retina. So peripheral hyperopic blur drives the eye to elongate. So what are the factors? Age is an important, strongest independent factor for myopia progression. Early the age of myopia onset, higher is the degree of myopia. Myopia progression is faster in younger children than older children. Then there is a higher prevalence in Asian children than white and Afro-Americans. And then again, urban population is having more prevalence of myopia compared to the rural population. Coming to the genetic factors, there are 39 genetic loci which has been mapped on the human genome. And if we talk about the Sydney myopia study, they say that if the one parent is myopic, there are 2 times risk. And if the 2 parents are myopic, there is 6 to 8 times risk. Then has been found association between outdoor and myopia, and it has been a lot of studies have been done and seen that children who spend more time outdoors have a lower risk of developing myopia compared to those who spend less time outdoors. The theory postulated is dopamine release, which alter the gene expression for axial length elongation. Australian study have found that children who spend 21 hours per week are non-myopic compared to the children who spend only 16.3 hours per week, which are myopic. A meta-analysis have found that 2% there is reduced odds of myopia per additional hour of time spent outdoors per week. And a recent prospective interventional studies have found that there is adding only 2 additional outdoor recess program of 20 minutes prevented the onset and development of myopia. Again, season also affects the myopia progression, and there's a slower rate in summers compared to the winters. Again, the near vision, there is a lot of studies have been done, and there is an evidence for a link between near work and myopia, but still the authors are divided. Like in Singapore study, they have found that more than 20.5 hours of reading a week is associated with myopia, whereas the Beijing myopia progression study have not found any significant difference. The Sydney myopia study says that if the child reads at a distance less than 30 centimeter and there is a continuity of near work more than 30 minutes, then there is a likelihood of myopia and the risk is 1.5 to 2.5. Then again, vitamin D levels has been associated with myopia. So now how can we control it and what are the options? So for that, we need to know the myopic profile of the child. It can be charted like environmental factors and the individual characteristics. In the environmental, you have to chart the lifestyle of the patient, and the guidelines should be given according to his lifestyle, and the modification should be told. Like the child can be asked to increase the time spent outdoor at least 2 hours per day. The use of near gadgets can be limited or restricted. The near work can be decreased. The child can be asked to take frequent breaks and follow 20-20-20 rule. Vitamin D rich foods can be included in diet, and the child can be asked to go more in sunlight. And again, vitamin D levels can be checked, and vitamin D supplements can be given if the child is found to have deficient. Again, based on the individual characteristic, we should look for the baseline orthoptic parameters, like if the child has esophoria, if the child has accommodation lag, both the refractive errors should be checked, and the MEM should be done both for the central and for the peripheral refraction in order to, and accordingly, the patient can be prescribed spectacles and contact lenses, which we'll be discussing further, and other pharmacological therapies are also there. Coming to the spectacle and lenses, the strategies which target the central refraction are bifocal spectacles and progressive spectacles. The Cochrane database study has found a limited and inconsistent results with the bifocal spectacles, but a recent randomized controlled trial in a Chinese Canadian children have found that the correction of bifocals is around 1 diopter per annum compared to the single vision lenses. And for the progressive spectacle also, the Cochrane database study have found clinically insignificant but statistically significant of around 0.5 diopter per annum. Now, status with peripheral refraction, we have positively aspherized progressive spectacles, and various studies have been done, and the mechanism is by reducing both the lag of accommodation and a hyperopic defocus on the peripheral retina. And they have found the correction to be around 1 diopter per annum compared to the single vision lenses. Then there are soft and multifocal contact lenses, and various studies have been done, and the efficacy has been found to be ranging from 30 to 70%. Then there are defocus incorporated multiple segments lenses, in which there is a central clear zone of 9 millimeter for the distance correction, and in the mid periphery there is a schematic array of multiple segments, each 1.03 mm in diameter, with a addition of 3.5 diopter, which causes a myopic defocus in the mid periphery. Then we have stellate lenses with HALT technology, which is highly aspherical lenslet target, in which there are concentric rings of contiguous lenslet with positive lenses, which causes myopic defocus in the mid periphery. Comparing the DIMS and the HALT studies, both the results are comparable. DIMS studies has shown has correction of around 0.75 diopter per annum, and the HALT study have found 1 diopter per annum. Then we have orthokeratology, in which rigid contact lenses are used to flatten the center of the cornea, which creates a myopic defocus in the mid-periphery. Comparing all of them, orthokeratology tops the list among all of them. Then coming to the pharmacological, atropine and 1% and low dose atropine have been more into picture. Atropine acts by non-specific muscarinic receptor. It blocks the muscarinic receptor non-selectively via neurochemical cascade. It also acts on the scleral fibroblast, increase the dopamine release, which in turn cancel out the retinal signal that control eye growth. So topical atropine has emerged as the most effective and promising treatment modality in myopia control for several decades. The ATOM-1 study was done by Chua et al., in which it was a placebo-controlled randomized double-mask study with 400 children, and they did a 2-year treatment and 1-year washout, and the efficacy was 77%, but there were a lot of side effects, and at the end of 3 years, there was significant rebound. Then with the lower strength ATOM-2 study was done by Chia et al. Again, it was a randomized double-mask clinical trial of 400 children. And they gave the children they randomized the children to 0.5, 0.1 and 0.01%. And they gave for the next 2 years. And the efficacy was seen highest with the highest strength, that is 0.5%. But as in the 3rd year, when there was a washout period, maximum rebound was seen with the higher strength. It was 68%. So all of them, those who had rebound, were restarted on 0.01% for the next 2 years. And at the end of 5 years, it was seen that 0.01% atropine has a similar efficacy compared to higher concentration with the minimal side effects. Then the LAMP study is one of the popular study. It has been done in a smaller children 4 to 12 years, and they have used 0.05 and lower strength 0.025, 0.01 and placebo. And among all of them, they have found that 0.05 atropine was the most effective for controlling myopia progression and axial length elongation. Then from India, we have an IATOM study, which is a multicentric, double-blinded, placebo-controlled, randomized controlled trial, which has recruited 100 children and reported a 1-year data. And they have found that the myopia progression was minus 0.16 in atropine and minus 0.35 in the placebo. And the reduction was 54%. The difference between the atropine and placebo group was only 0.19 diopter. It's because they had taken slow progression in their study. We also did a prospective placebo-controlled interventional trial at our center, PGIMR, to study the efficacy and safety of this drug in our population. The important things in our study was that we took only children who progressed equal to 0.5 or more than 0.5 diopter only for the next 1 year. And in one eye, we gave 0.01 drops, and in the other eye, we gave placebo. So we recruited 86 eyes, and rationale of our study was that effect of various confounding factors can be diminished if one eye of an individual receives the treatment and other eye of the same individual acts as the control. And we have also tried to find out how this drug behaves in a set of confounding factors compared to the placebo. So in our group, none of the patients had esophoria and none of them had accommodation lag, and the baseline myopia progression was 0.89 diopter. So coming to the results, in our study, the myopia progression in the treatment group was 0.25 and in the control, it was 0.69. And axial length elongation, it was 0.14 and 0.32 in the control group. So the efficacy of our drug was 66.67% in terms of myopia progression and 52.08% in terms of axial length elongation. When we compared the myopia progression and axial length elongation in treatment eyes with the age matched group, that is 6 to 12 years, our myopia progression was 0.35 diopter, and the ATOM-2, it was 0.43. So it was comparable with the ATOM-2. But in the LAMP study, the myopia progression was little higher because they took smaller children. So it was minus 0.59. And IATOM study, it was little lower because they took small, slow myopic progressions. In our study also, we found the drug to be safe. Pupil size change was around 0.5 mm, but no patient complained of any allergy or blurring of vision or photophobia or glare. We also, in our study, we had a structure validated questionnaire for various modifiable and non-modifiable factors. And we subdivided our children in various modifiable and non-modifiable factors depending on screen time, near work time, outdoor time for the modifiable, and not for the non-modifiable. We had age, baseline myopia progression, and family history. And this is the last slide. I want to conclude. And in our study, so we found that the one nightly dose of 0.01% was safe and effective. Reduction in myopia progression and axial length elongation was statistically significant in all children, irrespective of age group, baseline myopia progression, family history, screen time, near and outdoor time. I have not shown the results so far. I have just, because of the shortage of time, I just wanted to highlight the main points of my study. The strongest determinants of annual myopia progression were age and baseline myopia progression in my study. Screen time in control wise was associated by greater axial length elongation, meaning that screen time should be decreased. Drug efficacy was higher when outdoor time exceeded 2 hours per day. So all the children should be advised to spend more time in outdoor, while the efficacy was lower with prolonged near activities, with the fast progressors, and with the history of parental myopia. Thank you.
Thank you. Thank you, Dr. Shweta. That was a very informative, very well summarized talk on a very humongous topic. And I think we'll come back to the discussion. I have the final talk. I'll share my slides and we will then discuss the talks that I've already had. Let's start sharing my screen now. Good evening, everyone. I'm Dr. Hinav, and I work as an associate consultant at Shankar Nethralaya Eye Hospital in Chennai. I will be talking about biometry and IOL power calculation in children. Just a second here. So we all know that newborns have hyperopic eyes, and as the child grows, that there is an increase in axial length along with corneal flattening and lenticular flattening that leads to emetropization. The newborn eye grows in various phases. The first phase of growth has a maximum growth rate that is the first 6 months in life. They grow from what the newborn eye is about 16 to 17 millimeters, and it grows up to about 18 millimeters in the first phase of life. In the second phase, the rate of axial length growth reduces to about 0.8 millimeters to 1.2 millimeters, leading to a growth to about 21.5 millimeters during the second phase. And after the first 3 years, beyond 3 years of life, it really slows down. Along with corneal curvature flattening. So when children are born, they're born with really steep corneas, about 52 diopters of corneal astigmatism, which rapidly reduces in the first year of life. The lenticular power also rapidly reduces in the first year of life. So what are the challenges that we face in pediatric IOL calculation? Like I already discussed, myopic shift. Another very important one is that measurement of the axial length and the corneal curvature, what kind of IOL power formula that we need to use to calculate the IOL power, and what is going to be our target refraction. So axial length measurement, traditionally it has been done by two methods, applanation and immersion. Applanation, as we know, is very convenient. It is very accurate if we have a trained biometrist. The corneal compression is minimal, but it leads to about 0.24 to 0.32 millimeters of error, and it is more in pediatric eyes because of the low corneal and scleral rigidity. Immersion obviously is the gold standard of axial length measurement. We use a coupling fluid in a scleral cup, and there are no risks of errors from the extra pressure applied. Vasavda et al. Did a study, and they concluded that the contact technique on an average had a 0.27 millimeter shorter axial length than the immersion technique, leading to about 1 diopter stronger IOL power in younger children due to the corneal compression effect. And that effect was more due to the anterior chamber depth being reduced rather than corneal lenticular flattening. The second most important factor is the keratometry readings. We usually use a handheld keratometer in children as they are unable to sit and cooperate on a regular keratometer. The measurement should be taken without the use of an eyelid speculum so as to minimize any corneal steepening due to the effect of the speculum. And to avoid the corneal dryness, we need to maintain a smooth surface such as a balanced salt solution. At least 2 keratometry readings should be taken, and an average keratometry reading should be within 1 diopter of each other should be taken. But nowadays, we do have newer advances in biometry. We have the optical biometers. We have the Carl Zeiss partial coherence interferometer, the IOL Master 500, or the Lens Star, which also uses partial coherence interferometry. They have been shown to give very accurate biometry results in children. With the newer advances, we have the newer Swepsos IOL Master 700 or the IOL Master 900 now also. And using the Swepsos technology, we also have the Aladdin by the Topcon or the AL Scan by Nidec. The only drawback here in these optical biometers is that we need cooperation from the end of the child. We need the child to be stable. We need the child to be able to sit down. So it is possible in only slightly older children, I would say about 3 years and above if cooperative, but otherwise very practically possible in children who are 5 years and older. So younger than that, we still need to rely on the traditional axial length and keratometry methods. So there's a small comparison between IOL Master 500 and IOL Master 700 and 900, which does, so it's a very busy slide. I'm just going to conclude by saying that IOL Master 700 and 900 do have good comparable results, even in children. When we compare this optical biometry versus ultrasound biometry, we have studies by Lenhart et al. And Gursoy et al., which do show that optical biometry does give us more significantly accurate results than ultrasound biometry. But although they have been, the values that we get from both are comparable, hence validating the use of optical biometers in children as well. So let's come out to the third factor, that is what should be the target post-operative undercorrection. We need to target the residual hyperopia. So we need to see our ideal IOL power should balance out the amblyopia in childhood and the least refractive error in adulthood, which can be calculated by anticipating the expected myopic shift and thereby undercorrecting the eye that needs IOL implantation in the first setting itself. This initial hyperopia should be low enough to be corrected either with a contact lens or a glass and to facilitate compliance with amblyopia therapy. So how to determine this target post-op undercorrection? We have a lot of guidelines that have been proposed by, the most common ones that we use these days is proposed by Nyadi et al. The very easy way to remember this is that the age at surgery and the undercorrection that we need, the sum of which should be about 7, because they assume that the metropization or the eye reaches a 0 power by the age of 7 years. Plager et al. Also gives similar guidelines with slightly overcorrected target post-operative correction. Trivedi and Vinson et al. Are also very similar to Nyadi and Plager. Dahan et al. Gave guidelines based on axial length measurements, not very commonly used nowadays, but it can be used in children where you're planning customized IOL implantations in children with shorter axial lengths. So in about 17 millimeter eye, you ideally plan a 28 diopter lens. So you plan for about 20% undercorrection in children less than 2 years and about 10% undercorrection in children 2 to 8 years, and more than 8 years, you target emetropia. So what is the protocol? What to follow, when to follow? There are a few factors that you need to keep in mind. The age at the time of cataract surgery. If the child is younger, you do want to keep a relatively okay hyperopia there, because we know that if we leave the child with a large residual hyperopia, so large residual hyperopias are more amblyogenic than myopia. We need to look at the status of the fellow eye. The eye is if the fellow eye is also cataractous in case of bilateral cataracts, then the level of hyperopia should be equal among both eyes. But if the eye is phakic or the lens is clear, that is in case of unilateral cataracts or persistent fetal vasculature cases, we do need to aim at a little less hyperopia. Visual acuity, we need to look at the status of the fellow eye visual acuity. We need to look at the socioeconomic status of the children, where the child will comply, we need to decide whether there will be compliance of the child's family to refractive correction via contact lens or via glasses, or if they're going to be compliant towards occlusion therapy or not. We also need to look at bag or sulcus implantation of lens. We also need to look at whether we are going to plan a secondary IOL implantation a little later. If the parents are myopic, we do tend to keep the children a little more hyperopic because we anticipate a greater myopic shift in these children. So IOL power formula, what formula to use? It has been an age-old question. We have theoretical and regression formulas. The regression formulas are the SRK and the SRK2 formulas, which are based on mathematical analysis of post-operative results in eyes. So, and the theoretical formulas are the SRKT, Hoffer-Q, Holiday 1 and Holiday 2 formulas, which use the geometric optics. All these formulas have been validated for IOL power calculation in adults. However, there are very limited studies which have IOL power formulas which have been validated for children. In fact, none of these formulas have been derived by calculations on children. They have been derived by calculations on adults and then been validated for children. So there is no consensus. We have a lot of studies here which have compared formulas. So I'm just going to summarize a few of the important studies that I came across. Chang et al. States that in age less than 2 years, SRK2 has been, SRKT has been proven to be very accurate with less predictive errors. And in greater than 2 years, Barrett's, which is a new IOL power formula, has been pretty accurate. Kekunia et al. We have a study from India which differs from the other two studies, saying that SRK2 has the lowest prediction error. However, a lot of studies that I've come across, they do suggest that Barrett's is a universally good formula with less prediction errors in children at least over 2 years of age. A lot of other studies say that for shorter eyes, actual length shorter than 21 millimeters, Holiday 2 is also a good formula with the least prediction error. We also have the pediatric IOL calculator that has been designed by Gordon and Donzis, which is a modification of the SRK2 using the Holiday algorithm, and it attempts to predict the refraction of pseudophakic eyes as the child grows. It is based on this is one of the few calculators that is based on the primary data that has been collected through aphakic eyes in pediatric population, and it uses a computer software which is free of cost. It is available on the American Academy of Pediatric Ophthalmology and Strabismus website. So we have been using this pretty much in our clinical practice these days. So there are a few things that we need to keep in mind, that the actual length-based formulas give us about 80% predicted error within 0.5 diopters. OCT-based biometry has about 92% efficacy within 0.5 diopters. The Barrett's Universal 2 formula has about 98% efficacy or prediction error within 0.75 diopters. So my take-home message here is that the tailored approach is the best approach. We need to look at the child as a whole. We need to look at the family history. We need to look at the status of the other eye while we plan for biometry and target IOL power that we need to put in the child. Thank you. I'm going to stop sharing now, and I think we can move to the discussion part. Are there any questions from the audience that anybody would like to ask or put across? Okay, if I have a question actually to Dr. Shweta. All of the methods that you discussed are the methods that we have been following. We have incorporated DIMS, and we are now prescribing HALT as well. Low-dose atropine has been working wonderfully. But in my experience, all of these things work very well in children who have school-going or physiological myopia. Do you have any experience about using all of these things with good efficacy in children with, say, ROP-related myopia or other, progressive pathological myopias? I do have a lot of children who come in, parents being very, very concerned, 3 years of age, underwent indirect laser ophthalmoscopy for ROP, powers as high as -8 at 3 years, and they're still going to progress. So do you have any experience using atropine or these glasses for them?
Yeah, we have been prescribing in children with ROP, with myopia with ROP, but most of them you have to see that whether they are progressing or not. Most of them present at a later age when they have actually the number has stabilized. So you have to see if the child is progressing or not. I have tried in few of the patients, but the results are very inconsistent. I could not say it until I collect all the data and finalize it. But I would still say giving something is better than nothing. So we should be giving in that, and even they should be checked for the accommodation lag in these children. If they have accommodation lag, the bifocals also have a very good result. Because in our study, we have shown that low dose atropine corrects only around 0.45 diopter, not more than that. So again, if the child is progressing more than like 1.5 diopter per year, you cannot control only by this. So you have to combine with other modalities, whatever you have, based on the budget of the child also. So most of the time, bifocal is in their budget. So we have to see the child is properly wearing executive bifocals, because I have given few of them.
You usually give with the plus 2.5 ad, or you just start with
we check the accommodation lag in these children. But in large, 2 or 2.5 works best.
And
some of
you
the children
wean these children off the bifocals?
Sorry?
When do you start weaning these children off the bifocals?
Weaning, actually, again, if the child himself complain, you will find that the parents complain that he doesn't wear glass, or he just remove it. So by the time you check the accommodation lag again, and then you start weaning off. So depending on what is the need of the child. Again, checking the child is important. Again, because
Dr. Hayat Khan, if you're still here, this is in continuation with your myopia talk yesterday. I'm sorry if you're still up for it. I recently came across a few articles, even open for you, Dr. Shweta. Recently came across a few articles suggesting the use of repeated red light exposure for myopia control. Do you have any experience at your center, or Dr. Hayat, do you have any experience regarding that in your center? We have not been using it in our center. Most of the studies are from China. I'm not sure how effective it is. So I'm just asking for...
we have not done in our center.
Yeah. Hayat sir, if you're still here, we would like to hear your experience as well. Okay, I think sir is probably not here. Dr. Simarajan could not join us for the discussion as he had some prior commitments. Do we have any other questions? Okay, then I think we have ended our session well ahead in time, and I think sir is here now. Dr. Hayat, are you here? Are you?
Hello.
Hi, sir. So
sorry, I'm really sorry. I was actually in between my clinic. Sorry about that.
I'm very sorry.
No problem. Go ahead, please.
Okay, so my question to you was, one, in continuation with your talk yesterday, we were short on time yesterday, so we couldn't discuss. Do you have any experience with repeated red light exposure for myopia control? Like Dr. Shweta and me were discussing, they do not use it in their center. We don't use it in our center either. Do you?
I don't have that. This is not only here in the UK. Also, I have some of my colleagues who are using this. I don't have a personal experience with that.
Okay.
What do you think, Dr. Shweta?
Actually, we have not used, so it's a good idea to see, check the literature, and if we can do that at our center also, because I have no idea about, because we have not done at our center.
Yes.
Mm-hmm. Another question related to your talk from today, Dr. Hayat. You did talk about...
Assalamu alaikum, Dr. Khalid. كيف الحال? Can you please join? You are...
Yes. Can we continue, please? We have 1 minute. Go ahead with Dr. Dhillon.
Yeah, my last question to you is, when you perform a Y split, how much of a Y split do you perform? Like millimeter wise? Like do you...
So how much wide apart, you mean? That
no, I mean how much of the separation of the ends of the Y do you perform?
Exactly. Usually about 10 millimeter.
So 10 millimeters you take from the outer ends of the Y, or the inner ends?
Within the inner.
Within
the inner. So I think that works very well, and I have seen very good control, especially of the upshoots and the downshoots with that. Yes.
So, because literature is very inconsistent with how much of a Y you need to do for how much of an upshoot. So just gathering from personal experience.
I have always been about consistent with about 10
millimeters.
Well, somewhere around that. So I think it was worked very well.
All right. Thank you. Thank you.
I would
Thank you
like
very much.
to add a comment. Even sometimes LR periosteal fixation gives a very good result in case of very severe co-contraction. I have a lot of experience with LR periosteal, and it gives a very good result when you have, like, even the vice split sometimes fails in that when there's a severe co-contraction. In that case, LR periosteal does a
So
good
do you
job.
do periosteal fixation by yourself, or do you take help
No,
from
no,
your
I do by myself.
by yourself? All right. That's great.
Thank you so much.
Thank you. Thank you. I think this has
Thank you,
been
everybody, for
Thank you.
such an elaborative and a nice presentation. Thank you.
Thank you so much.
Yeah.
Okay.
I think over to you, Dr. Alamri. You can start the next session probably.